So, good morning. Let us start Salmonella today. Salmonella is a causative agent of typhoid fever, and Salmonella, non-typhoidal Salmonella, they are the causative agents of gastroenteritis and septicemia. So, the disease spectra of Salmonella can be divided into three particular disease. One is typhoid fever, the very common and most important disease of all, and gastroenteritis produced by non-typhoidal Salmonella. Typhoid is caused by Salmonella typhi, and other than there are almost about 2,500 species. They are responsible for. They are called non-typhoidal Salmonella, and they are responsible for gastroenteritis and septicemia. Salmonella typhi also can produce septicemia. So, let's discuss the Salmonella. Salmonella is placed under the group of Enterobacteriaceae. Enterobacteriaceae, they have the very common features, common characteristics they have. They are catalase positive, they are oxidase negative, they are non-sporing, they are facultative anaerobe. When motile with peritrichous flagella, that is flagella all over the body, peritrichous flagella, and when they ferment glucose, they produce acid and gas or only acid. They reduce nitrate to nitrite, and most importantly, they carry enterobacterial common antigen, and the GC ratio of this particular group is 29 to 59%. This is the entire definition of Enterobacteriaceae, what we ask in the oral table. So, what do you mean by Enterobacteriaceae? These are the group of intestinal organisms. So, certain characteristics are there. These certain characteristics include what I am just now tell you, that these are the characteristics of Enterobacteriaceae. Now, Salmonella, there is a clinical classification for the clinicians. Clinicianরা সবসময় বলে অত সব আপনাদের ঝামেলা ফামেলায় আমরা নেই। The simple thing they require. The simple thing is that classification is based on fermentation reaction. We have McConkey media. McConkey media where lactose is incorporated, and lactose fermenter group and lactose non-fermenter group. The simple classification. Lactose fermenter group are Escherichia coli and Klebsiella. Just for you, there are so many lactose fermenters are there. Some species of Citrobacter, Enterobacter, Serratia, Hapnia, and some species of Shigella soni. But for you people, please remember E. coli and Klebsiella. And the non-lactose fermenters are Salmonella, Shigella, Protea species. There are so many species also, Edwardsia, etc. For you, Salmonella, Shigella, and Proteus. So these are non-lactose fermenters. When they ferment lactose, the color of the media turns pink. Due to lactose fermentation, acid is produced, and in the McConkey media, we have one indicator. That indicator changes color, and the colony turns pink. And in case of non-lactose fermenter, the color is colorless. So Salmonella and Shigella, they produce colorless colony on cultivation on McConkey media. The colony characters of Salmonella, there are different type of colony characters. They may be convex type, they may be low convex type, they may be flat, they may be irregular, they may be carom coin shaped, and there are so many types of dome shaped, Staphylococcus dome shaped, pin-headed colony, like pinhead, Streptococcus pinpoint colony, Salmonella low convex colony, Escherichia coli convex colony, Klebsiella mucoid large colonies. There are different types of colonies are there. Streptococcus pneumoniae, carom coin shaped. There are different types. And these particular colony is colorless, low convex, entire margin colony. Three things you have to remember. Don't say those language, translucent, transparent, all these things bogus. Just remember whether it is lactose fermenter or non-lactose fermenter. If it is lactose fermenter, it will produce pink colony. Non-lactose fermenters have colorless colony. This is enough. In case of extra, I like to say, then come to the point whether it is convex or low convex. Salmonella, low convex type of colony it produces. Now, how will you differentiate Salmonella with Shigella? If you ask me, sir, Salmonella and Shigella is also colorless. Salmonella with Peritrichus flagella is motile, except two species, Gallinarium and Puloram. I remember with the certain mnemonics, Ganguram and Putiram. So these two are non-motile. All other Salmonella species are motile. So with Peritrichus flagella, Salmonella is motile. Shigella, non-motile. The simple differentiation. So these two colorless colony, but how will you differentiate? By motility test, sir. Shigella is non-motile, Salmonella is motile. Finished for you. Now this Salmonella, the flagellar antigen, you know, is H antigen. By the German language, Hauch, the H comes. So H antigen is a flagellar antigen. The somatic antigen is O antigen. And the outer layer of Salmonella, in certain cases, there is an outer layer, the surface layer, which is called the VI antigen. Virulence antigen, sometimes it was called as virulence antigen, but now it is considered, no, it is not related to virulence. It is VI antigen. Now this H antigen is heat labile, alcohol labile. It has two phases, phase 1 and phase 2. By the gene control, they express one type of flagella, they may express the second type of flagella, or they may express both. So if it is single flagellar type, H1 variety, then it is called monophasic. If both of the flagella are there, flagellar antigens are there, then this is called biphasic. So monophasic and biphasic. Sir, if you ask me, what is the importance of these things, sir? Monophasic, biphasic? Yes, that is an importance. The monophasic, this particular group is abbreviated in the taxonomy or nomenclature of flagella as small alphabet, small a, small b, small c, like that. And this is unique for each and every Salmonella. This is specific, by which we can carry the conformity test, that is antigen antibody test or agglutination test, by which we confirm the species of Salmonella. O antigen is not specific. So which antigen is specific? H antigen is specific. Which phase is specific? Sir, phase 1 is specific. Because there are so many variety of Salmonella, 2,500. But there is no history of sharing of this particular H1 conversion. Only H1, that antibody, that antigen is not shared. But O antigen is shared, H2 antigen is shared. So flagellar H1 is important for speciation of Salmonella species. That is the importance of H1. And this H1 species, with this, we perform the Vidal test, by which we diagnose Salmonella or typhoid fever. You have heard the name of Vidal test. Doctors often advise, you will also advise, in case of suspected Salmonella disease or typhoid fever, go for the Vidal test. So for the Vidal test, this antigen is incorporated. The O antigen is not stable. O antigen is stable, and O antigen is a lipopolysaccharide antigen. The LPS of all gram-negative bacteria, they produce endotoxin. So this lipopolysaccharide is not specific to all Salmonella. They are shared. These antigens are shared. So it is non-specific. the VI surface antigen, they often mask the H antigen and O antigen. Therefore, agglutination reaction is bit difficult until and unless you remove the VI antigen. The VI antigen is important for those patients who are carrying the salmonella even after complete recovery. For typhoid fever, the convalescent phase is there. The typhoid fever remission, everything okay, but still the patient is discharging salmonella through his or her species, stool or urine. And those patients, they are very much important for epidemiological purpose. One patient is there named as Typhoid Mary. You have heard the name. I'll show you the picture. So salmonella causes infections in human and vertebrates. The disease produces a typhoid fever, gastroenteritis and septicemia. The carrier state is important. This is the carrier state. In case of persistence of this outer surface VI antigen, the carrier state may occur, and we can identify this carrier state by doing this VI antigen test. If the titer is more than 1:10, then it is called the patient is carrying or convalescence carrier of salmonella or typhoid. A very complex group, 2000, more than 2000 now, more than 2500 species are there, and typed on the basis of serotyping, species typing, etc., and divided into two groups. Now you know. The enteric fever, typhoid fever, is caused by salmonella typhi as well as paratyphi A, B, C. Paratyphi A and B, these two are found in India, but C is not. So, typhoid fever, the causative agents in India is salmonella typhi, salmonella paratyphi A, and salmonella paratyphi B. And that's why in the Vidal test, the H antigen, considering its specificity, the H antigen is incorporated in the Vidal test as salmonella T, salmonella A, salmonella B. So these three are incorporated in the Vidal test, not C, and no VI antigen, because it is only done, this test, VI antigen is done only in England, not in India. So Indian kit, these are devoid of VI antigen. Typhoid Mary, the most dangerous woman in America, responsible for the food handler and responsible for spreading almost about 1,000 of patients with this carrier state. The morphology, it is gram-negative bacilli, as it is in the group of Enterobacteriaceae, so it is gram-negative, and those characteristics are there. Motile and motile with peritrichous flagella. The genus Salmonella belongs to Enterobacteriaceae, the facultative anaerobe gram-negative bacilli distinguished from other bacteria by antigenic structure of O, H, and VI antigen. The cultural characteristics. If we inoculate this into McConkey media, it will show non-lactose fermenter. Simultaneously, it has some selective media. Wilson-Blair's media, selenite F media. One important enrichment is required, because stool, from isolation of stool, is very difficult for salmonella, because stool contains so many of other bacteria. So we have to enrich one particular group, and we have to suppress the other salmonella or other bacteria present in the stool. That's why one selective media for enrichment is required, and that media, selective media for enrichment is the selective media for salmonella is for enrichment is selenite F media. What I prefer is selenite F. That is a very good media for culture. Selenite F media. For identifying enteric organisms, for biochemical test, you know one mnemonic is IMBU. I stand for indole, M for methyl red, V for VP test, Voges-Prescover test, U for urease, and C for citrate reactions. In case of Escherichia coli, it is IM positive, indole positive, methyl red positive, and VUC negative. Just the reverse in case of Klebsiella. VP positive, urease positive, citrate positive, but indole and methyl rate is negative. So it is very easy to remember, very easy to answer the questions in case of the differentiation between E. coli and Klebsiella. Im positive for E. coli and Vuk positive for Klebsiella. So in case of identifying this enteric organism, especially Salmonella, the Salmonella is methyl red positive, indole negative. Citrate, in some species citrate positive, otherwise all are negative. But in case of H2S fermentation, that is the TSI test, triple sugar iron test. You have seen triple sugar iron test in our lab? No. No. Triple sugar iron test. The result is K by A plus H2S. We often ask this question that what is K by A? K by A plus H2S. Salmonella typhi, the upper portion of the reaction of the TSI is alkaline. The lower portion is acidic. That's why K by A. And subsequently it produces H2S, hydrogen sulfide, from the triple sugar iron medium. And it is anaerogenic, no gas. So do not ferment lactose, but it ferment glucose, mannitol and maltose. Do not ferment lactose and sucrose, and typhoid bacilli are anaerogenic but never produce gas. Especially Salmonella typhi, they never produce gas, anaerogenic. Sorry. The antigenic characters now you know. H stands for flagellar antigen, O for somatic, and V for surface antigens. The importance of knowing these three antigens is to understand the classification of Salmonella. Long question. At least one alternate here. This comes as Salmonella. This is a question of theory question, that is classify copper and white skin. It's difficult to understand, but the basis of the classification is O antigen. On the basis of O antigen, initially copper and white classified Salmonella, 2,500 species. So we need one type of classification, copper and white. On the basis of O antigen classified Salmonella. O antigen, Salmonella is classified of alphabet A, B, C, C1, C2, C3 and up to Z except J. Later on, it was classified on the basis of Arabic numerals as 1, 2, 3 like that. And Salmonella typhi, the serotype, was allotted as 9, 12 and in bracket V1. In bracket V1 antigen, that means it is phage mediated. Bacteria phage mediated. That's why it is in box bracket. You see that there is sharing of 12 antigen by typhi, paratyphi A, paratyphi B and typhi medium. That's why Salmonella O antigen is not specific, because there is different sharing, different types of sharing between typhi, paratyphi and so many Salmonella. They are shared. That's it. O antigen is not specific. I have mentioned that H1 antigen, H1 phase 1, H1 phase 1 is specific because it is allotted D, A, B, etc. and not shared between the species. But once again, phase variation is there, and phase variation is a very important variation for confirmation of Salmonella species. How the phase variation is done? By the motility test. And that type of motility test is asked in the examination as known as Craigie tube motility. The Craigie tube motility, a tube is taken and semi-solid media is placed here. The semi-solid nutrient agar is 0.3% of nutrient agar. When added, it is called semi-solid nutrient agar. Usually 1 to 2%. But here the semi-solid media is prepared with 0.2 to 0.3% of agar. So this is the semi-solid media. And we place one tube, both ends open. And antisera against H1, antisera against H1 or H2 is added over here. Now, we introduce a particular type of salmonella through the hollow tube. So, that particular salmonella may have antigen H1, may have H2, may have both. That we don't know. So, in case of H1, the H1 is blocked here by the antisera. So, H1 antibody prevent flagellar movement of H1 antigen. Expression will be H2. Bacteria will convert its motility when motile, when biphasic. They have to express their motility. How they will show? They will convert the motility from H1 to H2. So a flip-flop mechanism is there. H1 is blocked, try H2. H2 is blocked, try H1. In case of biphasic. But when monophasic, there will be no movement. So if you collect a material from here and cultivate into a selective media, there will be no motility. And if it is biphasic, there will be the reverse type of motility. In case of biphasic, there may be expression. If you block H1, there will be H2. If you block H2, there will be H1. So this particular test is known as Craigie's tube and another type of motility test. In the oral examination, we ask for different type of motility test. You know, you please tell me, what are the motility test? One is the usual motility identification by the motility test. What you do here, by cover glass preparation. And another one is this Craigie's tube method in case of salmonella, where we can identify the phase variation, one of the conformity test. Now the motility is not always reversible. It may be also irreversible. So the reversibility of the media is tested, and one strain, one particular phenol agar media is used to show that type of motility is, whether it is H1 or H2. The motility can be sacrificed by using or cultivating it on the phenol agar media. 1:800 type of phenol is added, and then we can cultivate the salmonella species. There are a lot of phenotypic and genotypic variation. H, O to O, where loss of flagella. HO, if there is flagella, and loss of flagella species is only by O. And maybe phase variation, maybe smooth to rough variations are there. Now, how salmonella propagate? The propagation of salmonella, here is a picture for you. It enters intestine, especially ileal loop, and with the microvilli, find its attachment over here. This is salmonella with the attachment of surface particles are there with which it finds its attachment on the microvilli of ileal loop. Now from here it is internalized, and internalized after internalization, macrophage cell engulf them, phagocytosis. After engulfing macrophage there, the macrophage will propagate towards lymph node and they proliferate in the lymph node. That's why in salmonella and typhoid fever, the intestinal lymph nodes are affected because they propagate to the lymph node. And from there, the primary bacteremia occurs, and subsequently, second time, the bacteria, they enter the blood vessels and ultimately disseminated all over the body and in the liver, in the spleen, and everywhere. They may be present, and the result ultimately is septicemia. So from salmonella typhi and gastroenteritis, everywhere septicemia is a possibility, and septicemia identification is a bit difficult. Only by in the first week of typhoid fever, we can identify it by cultivating, that is blood culture, the only method. এই কি হলো? আচ্ছা, আবার এসে গেছে। Geographic distribution present all over the world. The typhoid fever is selectively a continuous or remittent fever. Clinical practice, we often term that as a remittent fever. Never touch the baseline. Baseline is 97, 98. It is always up, step ladder type, coming down and going up. The patient complaint is sir, জ্বর তো কমছে না, কখনোই 98 হচ্ছে না, সব সময় জ্বর হচ্ছে 98 থেকে 102 পরের দিন। A continuous type of fever, never touch the baseline, কখনো 97 হচ্ছে না। This is a particular type with constipation, slight neck pain. There may be bleeding also with stool. And these are the features of salmonella. Sometimes spot, rash. So this is characteristic fever in salmonella or typhoid fever. The pathogenesis of microfilaria, those I have explained. The pathogenesis, the immunity. The salmonella is clearly visible that the organism is intracellular, within the cell. If it is extracellular, the humoral immunity can take the upper hand. But here, it is intracellular. So, the cell-mediated immunity is the only way to clear it off. The cell-mediated immunity by interleukin 2, interleukin 6, tumor necrosis factor alpha, and interferon gamma. They activate the macrophage cells. And macrophage cell secretes nitrous oxide, a lethal toxin. With this, they destroy the intracellular organism. And sometimes there is also role of humoral antibody. But this is rare because humoral antibody has practically no role as the organism is intracellular. Similar thing occurs in case of viral disease. All the viral diseases are intracellular. So, the cell-mediated immunity can take the only important role to clear it off. The clinical manifestation include headache, malaise, anorexia, coated tongue, abdominal discomfort, constipation, diarrhea, step ladder type of fever. This is very important. And relative bradycardia. What is relative bradycardia? Any idea regarding relative bradycardia? For every degree rise of temperature, there is at least 10 count rise of pulse beat. Normal pulse beat is 72, say for example. Now my temperature is 99. My pulse beat will be 82. This is relative tachycardia. Normally what we expect? What doctors see on pulse? Palpating pulse. ডাক্তারবাবু বসে আছে পালস ধরে। কি দেখছে ছাতার মাথা? দেখছে এটাই যে টেম্পারেচারটা কত হয়েছে আর তার সঙ্গে তার পালস রেটটা প্যারালালি ম্যাচ করছে কিনা। দিস ইজ দ্য বেসিক থিং অফ ক্লিনিক্যাল আইডেন্টিফিকেশনস। ক্লিনিক্যাল তো আজকাল চলে গেছে, ক্লিনিক্স নেই, অল ডায়াগনস্টিক বেস, ডাক্তারদের ফেলিওর। তাই রিলেটিভ ব্র্যাডিকার্ডিয়া ইজ ভেরি ইম্পর্টেন্ট। প্রতি ডিগ্রি টেম্পারেচার বাড়বার জন্য পালস রেট 10 বাড়া দরকার। দ্যাট ইজ অ্যাবসেন্ট হিয়ার। সেটা এখানে নেই। টেম্পারেচার বেড়ে গেছে, পালস সেরকম বাড়েনি, which is called relative bradycardia. Rose spots appear. ছোট ছোট লাল স্পট সারা শরীরে অ্যাপিয়ার করতে পারে। এখানে তোমরা ওটা দেখেছো যে এই রেমিটেন্ট ভ্যারাইটি অফ টেম্পারেচারটা কেমন। এই যে রেমিটেন্ট ভ্যারাইটি বেস লাইন টাচ করছে না, যখন করলো তখন রেমিশন করেছে। টাইফয়েড ফিভারের র্যাশটা কেমন হয় দেখো, ডিসক্রিট র্যাশ, শরীরটা লাল হয়ে গেছে, পিঙ্ক ম্যাকুলার র্যাশ। কমপ্লিকেশনস কি হতে পারে? ইন্টেস্টিনাল পারফোরেশন, হেমারেজ, সার্কুলেটরি কোলাপস, মেনিনজাইটিস, অ্যান্ড এখানে মিস করেছে সেপ্টিসিমিয়া। আদার কমপ্লিকেশনস এর মধ্যে রিল্যাপস বারে বারে হতে পারে। এপিডেমিওলজি যদি দেখো তাহলে মেনলি স্যানিটেশনটা ইমপ্রুভ করা দরকার, জল থেকে হয়। আর তোমাদের ফুচকা, নানা রকম ফুচকা তো সাংঘাতিক স্টেরাইল, এটা ওটা করে তারপর ফুচকার জলটা হাত দিয়ে দিল, আলু কাবলি, চাট মশলা, এসবতে চান্সেস তো আছেই। টাইফয়েড মেরির কথা বললাম, ও ফুড হ্যান্ডলার ছিল, বহু লোককে ইনফেক্ট করেছে। তাহলে এবার আসি আমরা টাইফয়েড ফিভার কি করে ডায়াগনোসিস করব। তাহলে এখানে একটা ইম্পর্টেন্ট টেস্টের কথা বলেছি, হুইচ ইজ নোন অ্যাজ ভিরাল টেস্ট। কিন্তু ভিরাল টেস্ট সবসময় পজিটিভ হয় না। দিস টেস্ট ইজ ওনলি পজিটিভ ইন দ্য সেকেন্ড উইক অফ ফিভার। প্রথম সপ্তাহে তুমি দেখেছো যে কন্টিনিউয়াস টাইপ অফ টেম্পারেচার হচ্ছে, তুমি পেশেন্টকে ভিরাল টেস্ট অ্যাডভাইস করতে পারো না, বিকজ ভিরাল টেস্ট একটা ইমিউনোলজিক রেসপন্স। এই শোনো, ভিরাল টেস্ট তো লিখতে হবে প্রেসক্রিপশনে। তো ভিরাল টেস্ট একটা ইমিউনোলজিক টেস্ট, তাহলে সেটা কি করে করবে? সেটা ফার্স্ট উইকে লিখলে পেশেন্ট তো খেপে যাবে, হ্যাঁ, আর টেস্ট নেগেটিভ আসবে, তোমারও কোনো লাভ হবে না। সুতরাং তোমাকে করতে হবে যেটা, সেটা হচ্ছে ফার্স্ট উইকে ব্লাড কালচার ইজ অ্যাডভাইসড। Blood culture is the surest test to identify 90% positive rate. Subsequently, blood culture positivity to কমে যায়। Second phase 75%, তারপর 60%, তারপর 25%. Fourth week of fever. তাহলে ল্যাবরেটরি ডায়াগনোসিসের আমাদের গোল্ড স্ট্যান্ডার্ড হচ্ছে আইসোলেশন অফ ব্যাসিলাই, কি করে আমরা আইডেন্টিফাই করব, আর ডায়াগনোসিস অফ অ্যান্টিবডিজ, ভিরাল টেস্ট, ডায়াগনোসিস অফ অ্যান্টিবডি মানে ভিরালের এগেনস্টে, ওই ভিআই অ্যান্টিজেনের এগেনস্টে যে অ্যান্টিবডি শরীরে তৈরি হবে, দ্যাট ইজ ভিরাল অ্যান্টিজেন, সেটা আইডেন্টিফাই করতে পারি। অথবা ভিরাল টেস্ট করতে পারি আমরা এগেনস্ট টিএইচ, টিও অ্যান্ড এইচবিএইচ। আমি বলেছিলাম এইচ অ্যান্টিজেন ইজ স্পেসিফিক, সুতরাং আইডেন্টিফিকেশন অফ এইচ অ্যান্টিজেন ফর সালমোনেলা টাইফি, টিএইচ, সালমোনেলা প্যারাটাইফি অ্যান্ড সালমোনেলা প্যারাটাইফি বি ফর ইন্ডিয়ান, এই তিনটে আইডেন্টিফিকেশন, এই তিনটেই কর্পোরেট করা আছে ভিরাল টেস্ট। চলো আমরা দেখে নিচ্ছি পরে। সো ব্লাড কালচার statistically খুব ইম্পর্টেন্ট, যে ব্লাড কালচার ইজ 90% পজিটিভ ইন ফার্স্ট উইক অফ টাইফয়েড ফিভার। সো অলওয়েজ গো ফর ব্লাড কালচার ইন দ্য ফার্স্ট উইক। কি মিডিয়ায় করবে ব্লাড কালচার? ইন্টেস্টিনাল অর্গানিজম, বাইলে ভালো গ্রোথ আসবে, সো বাইল ব্রথ মিডিয়া খুব ভালো মিডিয়া। ব্রেন হার্ট ইনফিউশন ব্রথ। কাস্টানেডা মডেল যেটা আছে, কাস্টানেডা বলে একটা বটল আছে, সেই বটলটা বাইফেজিক মিডিয়া, কাস্টানেডা বটল, মানে একদিকে সলিড আরেকদিকে লিকুইড, বোথ ফেজ। কারণ সলিড থেকে বারে বারে কালচার করতে গেলে কন্টামিনেশন হতে পারে, তাই বোথ ফেজেস আর দেয়ার, সলিড ফেজ আর লিকুইড ফেজ ইজ কাস্টানেডাস মেথড। সালমোনেলা অন ম্যাককনকি, কালারলেস কলোনি আসবে, কালারলেস কলোনি, এখানে দেখতে পাচ্ছ এই কলোনিগুলো কালারলেস, low convex, entire margin, colorless colony. XLD বলে একটা মিডিয়া আছে, XLD মিডিয়াতে ব্ল্যাক কলোনি আসে। ক্লট কালচার আরেকটা মেথড আছে, আর অটোমেটেড সিস্টেমে ব্যাকটেক অ্যান্ড রেডিওমেট্রিক মেথডস আছে, যেগুলো আপডেটেড এবং রিসেন্ট মেথডস। বায়োকেমিক্যাল ক্যারেক্টার্স আগেই আলোচনা হয়ে গেছে। Slide agglutination test এলো from unknown culture, isolate is mixed and clumping occurs within few minutes যদি তুমি স্পেসিফিক অ্যান্টিজেন দিয়ে করো। টেট্রাথায়োনের ব্রথের কথা বলেছি, আর সেলেনাইট ব্রথ, এগুলো দিয়ে এনরিচ করতে হয় স্টুল স্পেসিমেনকে। স্টুলে অনেক রকম অর্গানিজম থাকে, সুতরাং শুধু যদি সালমোনেলাকে আর সিগেলাকে ধরতে হয় তাহলে এনরিচমেন্ট লাগবে। সেরোলজি, টিউব অ্যাগ্লুটিনেশন টেস্ট অ্যান্ড স্ক্রিনিং টেস্ট, ভিরাল টেস্ট। ভিরালের মধ্যে we detects the O and H antibody, diagnosis of typhoid and paratyphoid, and testing for H agglutinin in Dreyer's tube and a narrow tube flocules at the bottom. Dreyer's tubes এর আমি ছবি দেখাবো, ছবি দেখাচ্ছি, ছবি আছে। আর ও অ্যান্টিজেনটা ফিলিক্স টিউবে যেটা হবে সেটা হচ্ছে চকের গুঁড়োর মতো হবে, একটা ফ্লোকিউলস হবে, উলি গ্রোথ হবে, আর একটা উলি হবে না। সেকেন্ড উইক অফ ফিভার ইম্পর্টেন্ট। কখন ভিরাল টেস্ট অ্যাডভাইস করবে? দ্য সেকেন্ড উইকে দ্য রাইজিং টাইটার ইজ ইম্পর্টেন্ট। রাইজিং টাইটার পরপর দুটো টেস্ট করতে হবে, 3 দিন 4 দিন গ্যাপে। যদি দেখা যায় টাইটার ইজ ইনক্রিজিং, দেন অনলি দ্যাট ইজ সিগনিফিকেন্ট। দ্য পারসিস্টেন্ট টাইটার, ভিরালে যেহেতু টিএবি ভ্যাকসিনটা ইউজুয়ালি দেওয়া হয়, সো আফটার গিভিং টিএবি ভ্যাকসিন, so after giving this TAB vaccine, usually there is a rise in titer. The significant titer যেটা ভিরালে সেটা হচ্ছে more than 160. So rising titer above 160 is significant. এগুলো নিয়ে যদি কিছু জানবার থাকে তাহলে আমার ওখানে চলে এসো। কিছু বোঝা গেল না? মাথার উপর দিয়ে চলে গেল? কিছু বুঝেছো? সালমোনেলা কিন্তু খুব ডিফিকাল্ট, আর সালমোনেলা থেকে অনেক প্রশ্ন আমরা জিজ্ঞেস করি। যাই হোক, ভ্যাকসিন আছে, টিএবি ভ্যাকসিন, আর আছে টাইফোরাল ভ্যাকসিন, ওরাল ভ্যাকসিন। সেখানে একটা স্ট্রেন ইনকর্পোরেট করা হয় TY21A, এই ভ্যাকসিনটা আজকাল চলছে, ওরাল ভ্যাকসিন। ইনজেক্টেবল ভ্যাকসিনও আছে ভিআই ইনকর্পোরেট করে। ট্রিটমেন্টে সালমোনেলা গ্যাস্ট্রোএন্টেরাইটিসটা একটা সময় খুব ছাপ ফেলেছিল। ভাঙা পোলট্রি থেকে ভাঙা ডিম খেয়ে আর প্রপারলি বা আনকুকড মাছ মাংস খেয়ে সালমোনেলোসিস স্প্রেড করেছিল 1998 থেকে 2000 এরকম সময়। So at that time we found that the organism is resistant to chloramphenicol. The drug of choice is chloramphenicol, and at that time it was chloramphenicol resistant. Only it responds to ciprofloxacin variety. Carrier ke tarabar jonno we use sulfonamide groups. Salmonella gastroenteritis is caused by all salmonella except Salmonella typhi. Non-typhoidal salmonella বলে, non-typhoidal gastroenteritis হতে পারে। Bacteremia endovascular infection is also precipitated out. Salmonella gastroenteritis can occur as cross infection. হাসপাতালেও হতে পারে, hospital acquired. Manifest with diarrhea, vomiting and abdominal pain, etc. Treatment isolation, culture করে isolation করতে হয়। Salmonella septicemia by Salmonella cholera suis, এটা ওই পোলট্রি থেকে হয়েছিল, and deep abscess and endocarditis was precipitated out. So this is all about Salmonella. এখন এর বাইরে যদি কিছু জানার থাকে তাহলে আমার ওখানে এসো, আমি আলাদা করে অনেক কিছু যেগুলো বলিনি, আমার মনে হলো তোমরা ঠিক বোধহয় শেষ দিকটা ফলো করতে পারছো না, তাই আমি ডিটেলসটা বললাম না। অনেক কিছু বলার ছিল, যেমন ভিডাল টেস্ট নিয়ে, ব্লাড কালচার নিয়ে। ব্লাড কালচারটা ভীষণ ইম্পর্টেন্ট টেস্ট, আমরা মাঝে মাঝেই অ্যাডভাইস করি, এবং ব্লাড কালচারটা ডিটেলস জানতে হয়, না হলে পেশেন্টের রিপোর্ট ইন্টারপ্রিট করা যায় না। পেশেন্টের রিপোর্ট ইন্টারপ্রিটেশনে কতগুলো আইডিয়া ব্লাড কালচার সম্পর্কে থাকা দরকার। অ্যান্ড অ্যাজ ওয়েল অ্যাজ ইন ভিডাল কেস, তুমি ভিডাল পজিটিভ দেখলে, বাট দ্যাট মে বি ফলস পজিটিভ। সুতরাং ইন্টারপ্রিটেশনস অফ এ রিপোর্ট is very important for clinical identification diagnosis purpose. টাইফয়েড ফিভার ডায়াগনোসিস করতে না পারলে তো আর আমরা ডাক্তারি করতে পারবো না, কারণ এটা বেসিক সবসময় আসছে আমাদের চেম্বারে with the particular type of temperature, and we have to advise accordingly as per their sufferings. কতদিনের হচ্ছে, ফার্স্ট উইক অফ ফিভার আর সেকেন্ড উইক অফ ফিভার। একটা নেমোনিক আমি বলে যেতে পারি, সেটা হচ্ছে টাইফয়েড ফিভারের জন্য খুব ইম্পর্টেন্ট। সেটা হচ্ছে পরীক্ষার হলের জন্য কি করে মনে রাখতে হয়, সালমোনেলা পরীক্ষায় জিজ্ঞেস করবেই করবে যে কোন টেস্ট কখন অ্যাডভাইস করবে, কারণ এটা একটু কমপ্লিকেটেড। ওরা এটা জিজ্ঞেস করে যে ফার্স্ট উইক অফ ফিভারে কোন টেস্ট লিখবে, সেকেন্ড উইক, ফার্স্ট উইক অফ ফিভারে কোন টেস্ট অ্যাডভাইস করবে, সেকেন্ড উইকে কোনটা করবে, থার্ড উইক অফ ফিভারে কি করবে, ফোর্থ উইকে কি করবে। এটা পরীক্ষায় ধরবেই ধরবে। সব এক্সামিনারের ফেভারিট, আর সালমোনেলা আমাদের ভীষণ ফেভারিট, কারণ ওটা ডাক্তারদের ব্রেড অ্যান্ড বাটার। টাইফয়েড ফিভার আইডেন্টিফিকেশন না করতে পারলে কিছুই হলো না। তো নেমোনিকিস, এটা জেনে রাখো। বাসু বাসু, আসবু আসবু। বি is blood culture. Bashu. First week of fever, blood culture, sir. The next preferred test, sir, agglutination reaction, that is Vidal test. Next, sir, stool culture. Next, urine culture. So blood culture, agglutination reaction by Vidal, stool culture and urine culture. This is the preference in first week of fever. The second week is almost same because the positivity rate of blood culture in the first week is 90%. Subsequently, in the second week is 75%. So it is also Bashu. The third week of fever, patient tested tomar kache clinically. They will ask you, what is your preference of tests? Sir, don't say Asbu. Say agglutination reaction in the third week and followed by stool culture, then blood culture and urine culture subsequently. So Bashu, Bashu, Asbu, Asbu. This is the quote. এটা মনে রাখলে মোটামুটি ওরাল টেবিল হয়ে গেল। এই একটা ট্রিকি কোশ্চেন।
Let's begin today's topic. Male 5 years old, a 5-year-old boy presented to the pediatrics OPD. A 5-year-old boy presented to the pediatric OPD with complaints of what? With complaints of protuberant abdomen, history of multiple blood transfusion. There is history of multiple blood transfusion. Can you see? Can all of you see? Huh? There is unconjugated Okay, so a 5-year-old male patient presented to the pediatric OPD, 5-year-old male patient presented to the pediatric OPD with protuberant abdomen. That is one of the features. The patient can have other features also. There is history of multiple blood transfusion. Patient gives a history of multiple blood transfusion. Biochemical examination reveals unconjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia. So what is your provisional diagnosis in this case? Huh? What? Thalassemia major. Okay, how do you classify thalassemia? Which kind of thalassemia is it? Huh? So, beta thalassemia, because your exam is closed, I'm just going to discuss this topic based on how you're going to approach, how you're going to write the answer, okay? Because you don't have enough time. So, our topic today is thalassemia. So the cardinal features of thalassemia, because there is alpha thalassemia, depending on which gene is affected, you can have alpha thalassemia and beta thalassemia. But because beta thalassemia is more common and more severe than alpha thalassemia, and of course from your exam point of view also, so we're going to concentrate on beta thalassemia. And beta thalassemia has major, intermediate and minor. Features are more or less similar. The only difference is in beta thalassemia major, the symptoms will be much severe. Otherwise, the common denominator of beta thalassemia, whether it's the major, intermediate, minor, they are all same. The only difference lies in the clinical severity. Major will manifest more, okay? And major is more dangerous, as the name suggests. So going with this theory, we are going to concentrate whatever I am going to discuss now is beta thalassemia major. Okay, so what is thalassemia? How do you define thalassemia? It's a heterogeneous group of disorders. It's a heterogeneous group of disorders characterized by inherited mutations. Characterized by inherited mutations, which cause, I've written it as alpha and beta because I couldn't find those figures in the net. I mean, in the computer. So A stands for alpha, B stands for beta. Okay. So it is characterized by reduction in production of either alpha or beta chains. Characterized by reduction in alpha or beta chains, which leads to tissue hypoxia, anemia. First there will be anemia, and because of anemia there will be tissue hypoxia and red cell hemolysis. Red cell hemolysis. Okay, so this is the cardinal feature. It's a heterogeneous group of disorders caused by inherited mutations. So it is not an acquired case. So far we don't know if thalassemia has any acquired etiology. It's only inherited etiology. So mutations. Certain Hey, you're gonna push. Sit here. Heterogeneous group of disorders characterized by inherited mutations resulting in reduced production of the alpha or beta chains, leading to anemia, tissue hypoxia, and red cell hemolysis. So alpha thalassemia is due to deficient synthesis of alpha chain. A stands for alpha, B stands for beta. So alpha thalassemia is because of reduced or deficient synthesis or absent alpha chain. The pathology lies in the alpha chain, and beta thalassemia in beta chain. So you know all this. I'm not explaining sickle cell anemia te egulo kotha hoye geche last class normal amader which is the adult hemoglobin maximum is HbA tachara ache to a certain extent HbA2 and HbF, which is the fetal hemoglobin, and normal hemoglobin structure too. What is the normal structure of hemoglobin? Two alpha chains and two beta chains, right? A pair of alpha and a pair of beta chains. So I'm not spending too much time on this. So classification. Amitam Mutadichi, okay? So classification will be one based on clinical features. First and foremost thing, based on clinical features, which is dependent on gene defect, দেখা যাচ্ছে, which is dependent on gene defect, which ultimately is dependent on gene dosage. Okay, so gene dosage means whether it's homozygous or heterozygous. Homozygous or heterozygous. Gene defect, whether it's beta 0 thalassemia. What is beta 0 thalassemia? There is absolutely no beta chain production. There is absolutely zero synthesis of beta chain. So that is beta 0 thalassemia. What is beta plus? Some beta chain is produced. Some beta chain is produced. Okay? And then beta thalassemia means this is normal. This is normal. Beta thalassemia trait, jeta trait e thake. Okay? So beta 0 is there is absolutely no synthesis of beta chain. Beta plus is there is কি হচ্ছে? হ্যাঁ? Beta 0 is there is no synthesis of beta chain. Beta plus is there is some beta chain synthesis, and beta means normal. Okay, so what is a homozygous then? Like thalassemia major, beta 0, ami aski ota. And then based on the clinical severity, you got major, intermediate, and minor. So this is how you have to go. Gene dosage sum ekhane likhin, I haven't mentioned it, but if possible, if they ask you, please make a mention of gene dosage. And because of gene dosage, whether it's homozygous or heterozygous, it will give rise to gene defect, beta 0, beta plus, or beta. And finally, beta thalassemia genes are affected. Based on that, you have the clinical features, whether it's patient will present with major or intermediate or minor. So this is basically the classification that you have to know. Okay. Okay, I'm going to the next slide. So just remember this, they will not ask you these questions. The most common mutation is point mutation. Point mutation again is of three types. One is splicing mutation, the other is promoter region mutation, and the third one is chain terminator mutations. So in splicing mutations, you get both beta 0 thalassemia and beta plus thalassemia, means there is some synthesis of beta chain in splicing mutations. Whereas chain terminator mutations, as the name suggests, there is absolutely no beta chain synthesis. It's a absolutely beta 0 thalassemia. And in between you have the promoter region mutations where transcription is reduced by 75 to 80%, where you get beta plus mutations. Just remember this name and in which particular mutation, how many beta chains are synthesized. So the common is point mutation. The mutation that happens in thalassemia, beta thalassemia, is point mutation. In point mutation, you can again divide it into splicing mutations, where you get both beta plus and beta 0 thalassemia, means some beta chain is synthesized. Then you get the promoter region mutations, where it's only beta plus, means some chain is synthesized, and the last one is chain terminator mutations, where absolutely no beta chain is synthesized. So this is a beta 0 thalassemia. Okay, just remember the names, that's enough. So now coming to the clinical classification, don't concentrate on this, I'll be just explaining you this. Okay, because it's a big topic. Robin Korish, hey, Robin Korish to Robin se ache. Okay, লাগবে না, Robin se ache. So we divide it into beta thalassemia major. Beta thalassemia major is homozygous beta thalassemia. Homozygous beta thalassemia means there is either it's beta 0, means there is absolutely no beta chain synthesis, or beta plus, or beta 0, beta plus. So in major, either beta 0, beta plus, or beta plus, beta plus. So clinical features is severe. In this case, the clinical features will be severe. The patient has to depend on blood transfusion for survival. The patient must be transfused with regular blood, only then the patient can survive. So that is homozygous. Means there is absolutely no normal beta chain. There is no normal beta chain. Beta is not there. Either it's beta 0 or it's beta plus. Both are pathological. And even though it is beta plus, but the chain that is synthesized, but it's not enough for survival. Beta plus is not enough for survival. The patient has to be transfused with blood. In the end, you have beta thalassemia minor. Beta thalassemia minor is heterozygous, because there is normal beta chain synthesis. Either it's beta 0 beta or beta plus beta. Beta 0 beta or beta plus beta. Here, the patient survives without blood transfusion because there is one normal allele. The patient presents with microcytic anemia, but it's mostly asymptomatic. So beta thalassemia in iron deficiency anemia, what is the differential diagnosis of iron deficiency anemia? What type of anemia is thalassemia? Microcytic hypochromic anemia. And you have studied in iron deficiency anemia, which is also microcytic hypochromic anemia. So what is the difference in differential diagnosis? What would be the differential diagnosis of microcytic hypochromic anemia then? Iron deficiency anemia with thalassemia. Right? Thalassemia can be a differential diagnosis. Which thalassemia? Thalassemia minor. Never say thalassemia major. A differential diagnosis of iron deficiency anemia is what? Thalassemia minor. Don't say thalassemia major. And yes, RDW you are saying. What is RDW? Red cell distribution with pH change or what changes take place? Height increases in iron deficiency anemia, it increases. In thalassemia, it remains normal. Okay. So, beta thalassemia minor is heterozygous beta thalassemia where one gene is defective and the other gene is normal. There is one beta. Okay, so the patient is asymptomatic with mild or absent anemia. The patient may have microcytic anemia. No blood transfusion is required. And in between you have the beta thalassemia intermediate, which is also severe but does not always require blood transfusion. Okay, so remember this classification and remember how many genes are being affected. Okay, so beta thalassemia major, beta thalassemia intermediate, which is variable, beta thalassemia major is homozygous, beta thalassemia intermediate is variable, and beta thalassemia minor is heterozygous. So remember these points. This is very important. Eta jodi mathay thake, you won't have any problem understanding. Okay. So how does it affect? I'm just teaching you exactly how you should write in the paper. How does it affect? First and foremost thing is accumulation of free alpha chains. There is a relative increase in alpha chains. How? How? When beta is not present, naturally there will be a relative increase in alpha chain, right? So you get that point. Number 2 is extravascular hemolysis. Extravascular hemolysis. How does extravascular hemolysis occur? Extravascular hemolysis means what? Yes, how does it occur? Why it happens and how does it occur? See, for example, say this is the red cell. If this is the red cell and alpha chains accumulate, if this is the red cell and alpha chains accumulate, okay, there will be a relative increase. Okay, pairing ka to hobe na. So they will accumulate and form what? Inclusions. And they will form inclusions, right? And this particular red cells will also have membrane defects. This red cells will also have membrane defect. So 75 to 80% of the cells will die inside the bone marrow. 75 to 80% of the cells will die inside the bone marrow via the process of apoptosis. 75 to 80% of the cells will die in the bone marrow via the process of what? Apoptosis. The remaining, which manages to leave the bone marrow and enter the peripheral circulation, the remaining, which leaves the bone marrow and manages to escape into the peripheral circulation because of the intrinsic damage. Because of the intrinsic damage. When they pass through the spleen, are sequestered or devoured by splenic macrophages. This is the reason why you get extravascular hemolysis. This is the reason why you get extravascular hemolysis. And to a certain extent, this may be one reason why there is splenomegaly, protuberant abdomen. Is it clear? Keno hote pare? Because the spleen is working more, just like hyperplasia. You're working on your arms, you're working on your back, you're working on any part of the body, gymming, your muscles increase in size. Right? Hypertrophy or hyperplasia. Same thing happens because the splenic macrophages are constantly attacking the red cells. It's working more. There is splenomegaly. There are other reasons also. I'll come to that. So the most important thing is how accumulation of free alpha chains results in extravascular hemolysis. Correct? This is the reason why it happens. Number 3 is certain bone changes. Certain bone changes. Why does bone changes happen? Why does bone changes happen? And one more thing, bone changes is but tell me, why does bone changes happen? When there is hemolysis, what will happen if there is hemolysis? Huh? Bone marrow hyperplasia. Which lineage? Erythroid lineage. Remember, the megakaryocyte and myeloid lineages are not involved. The WBC and platelet lineages, the myeloid and megakaryocytic lineages are not involved. So only in thalassemia, the erythroid lineage is involved. Now there is hemolysis. What will happen in case if there is hemolysis? What will happen? Red blood cell that is being destroyed. So what will happen? The bone marrow will try to compensate. The bone marrow will try to compensate for the loss. Means there will be erythroid hyperplasia. There will be more production of cells of the erythroid series, means red blood cells. The bone marrow has to work more to produce. And at some point of time, so in adults, the long bones are the sites of bone marrow production. But in this case, the sternum, the ribs, the skull, anywhere, even in the soft tissues in various organs, liver, spleen, etc., there will be hemolysis because the body has to produce more and more cells of erythroid lineage, more and more RBCs because it is being destroyed. So the cell has to produce. So not only one place has to, not only the long bones are the erythroid manufacture cannot just confine themselves to the long bones. It has to take place in the flat bones like the sternum, the ribs, the skull, which are normally not the sites. Then in various soft tissues like the liver, spleen, etc., etc. Okay. So then what happens? Because there is erythroid hyperplasia, it will erode the bony cortex. It will erode the bony cortex, resulting in new bone formation. Resulting in new bone formation. This is known as crew cut appearance. Crew or hair on end appearance. Army cut like army cut it ঠিক army cut এর মতো লাগে. It's called crew cut appearance or hair on end appearance. নিয়ে আসছি ওটাতে. Okay. Then extramedullary hemopoiesis, I have explained you why. Extramedullary hemopoiesis. And then comes iron overload. Iron overload. What happens? Why iron overload? There is increased absorption of iron. One. Why there is increased absorption of iron? I'll show you the picture. This erythroblast produce an enzyme called erythroporin. They produce an enzyme called erythroporin, which downregulates the synthesis of hepcidin. Hepcidin is a negative regulator of iron absorption. So when hepcidin, which is a negative regulator of iron absorption, their synthesis is degraded or downregulated, iron overload. So this is basically the picture. This is basically the picture which I have explained just now. Wait. This is basically the picture which I have explained just now. Does this picture need explanation once again? Does this picture need explanation once again? The first and foremost thing is, see, in normal you have HbA, alpha 2, beta 2. In case of thalassemia, you do not have, you have deficient beta chain synthesis, which results in a relative increase in the alpha chains, resulting in what? Inclusions. Resulting in inclusions. So these red cells inside the bone marrow, these red cells in the bone marrow, which bear these inclusions, have defective red cell membrane. Most of the cells die via the process of apoptosis. Most of the cells die via the process of apoptosis. Some of the cells which manage to leave, so some of the cells which manage to leave the bone marrow and enter the peripheral circulation are devoured, are trapped in the splenic, which manage to leave the peripheral circulation, which manage to leave the bone marrow, enter the peripheral circulation, are trapped in the spleen and devoured by the splenic macrophages, resulting in extravascular hemolysis. Resulting in extravascular hemolysis. Right? And the other pictures you know how it happens, how iron overload happens. So this ineffective erythropoiesis results in what? Anemia, which results in tissue hypoxia. If there is tissue hypoxia, there will be increased erythropoietin production. কোথা থেকে erythropoietin produce হয়? JG cells, right? Juxtaglomerular cells. JG cells, I forgot physiology. Which results in marrow expansion. I told you marrow expansion and what are the changes that will take place. And also, there will be increased iron absorption. One major reason for increased iron absorption is the production of erythropoietin. Production of erythropoietin, which is a negative regulator of iron, which degrades or downregulates the synthesis of hepcidin by the liver, which downregulates the synthesis of hepcidin by the liver, resulting in what? Increased iron absorption, because hepcidin is a negative regulator of iron absorption. Okay, so that's why you get the systemic iron overload, and of course, these patients thrive on blood transfusion. To survive, they must be transfused with blood. So on one hand, there is increased absorption of iron in the gut, which is accompanied by multiple blood transfusions. So these patients have iron overload. These patients have what? Iron overload. So you get this systemic iron overload, which is called hemochromatosis, which are deposited in various parenchymal organs like the heart, the kidney, spleen, liver, etc., etc. Then you get skeletal deformities and extravascular hemolysis. So in a nutshell, this is basically the pathology. And even if you don't draw this diagram, it doesn't matter. If you can represent it systematically, schematically, in a tabular format, in a flow chart rather, that's more than enough. Okay. So I'm going to the next slide. So this almost explains the entire pathology. So this is basically the mechanism of iron overload, which I have explained. Increased erythroferron, increased erythroferron production, downregulating the production of hepcidin by the liver, and hepcidin being a negative regulator of iron. When there is no hepcidin, there will be increased absorption of iron. Okay? So is that clear? So you have to explain these things. Extravascular, how free chains accumulate, what happens if there is free change, there is the extravascular hemolysis, then there will be iron overload, all these things, how bone changes happen, all these things must be explained. Just don't put the heading, just explain a little if the question is asked. So coming to the clinical features, these patients are asymptomatic at birth. Up to the first 3 months of life, they are asymptomatic simply because there is HbF. HbF compensates for beta chain. HbF compensates for the beta chain. But once the HbF level starts to wane after 3 months, HbF level falls. That's when the patient, because there is no beta chain synthesis, that's when the patient starts to manifest clinically. First 3 months of life, there is absolutely no problem because HbF compensates for it. But after 3 months of life, when HbF level starts to fall, starts to wane, and that's the time when beta chain synthesis should begin, and there is no production of beta chains, that's when the patient starts to manifest clinically. Okay. The symptoms begin in the first 3 months of life, and the patient presents with anemia, failure to thrive, poor feeding, intermittent infections, thalassaemic phases. This is known as a thalassaemic phases. Sorry. This is known as a thalassaemic phases because there will be marrow expansion. That particular phase is known as thalassaemic phases. Then you get protuberant abdomen, and biochemically you get unconjugated hyperbilirubinemia because of hemolysis. Because of hemolysis. Okay. So this is exactly the bone change that I'm talking about. This is the bone change that I'm talking about. True cut appearance or hair on end appearance. Why? Because the erythroid hypoplasia will erode the bony cortex. The erythroid hypoplasia will erode the bony cortex and result in, because there is a fracture of the bone, it will cause new bone formation. So that particular thing is seen in X-ray as hair on end appearance. Hair on end, hair on end appearance or crew cut appearance. Crew cut appearance or hair on end appearance. Then you get the mosaic pattern of bone formation, which are mostly seen in metacarpals, metatarsals, and phalanges. Then osteoporosis. If you write hair on end appearance and why it happens, that is more than sufficient. Other than that, there is growth and development. There is short stature and large head, delayed puberty, all because of iron deposition. Then you get the endocrine dysfunction, growth hormone deficiency, hypothyroidism, hypoparathyroidism, and diabetes mellitus. If iron is deposited in the pancreas, the beta cells of islets of Langerhans are involved, they are affected, there will be no secretion of insulin, resulting in diabetes mellitus. Okay. So coming to the lab evaluation, which is very important. Coming to the lab evaluation, which is very important. So what are you going to evaluate? Complete blood count. First and foremost thing is a complete blood count. See, complete blood count and PBS. What is PBS? Peripheral blood smear. So what is the difference between a CBC and a PBS? What is the difference between a complete blood count and a peripheral blood smear? Huh? In complete blood count, you get everything. PBS is included in complete blood count. So when a doctor advises a CBC, after 10 years, when you'll be practicing and you'll be giving a CBC, you must know which parameters you have given. A CBC includes hemoglobin. It includes the total count, means total WBC count. Differential count means neutrophils, eosinophils, basophils, lymphocytes, etc., etc. That differential count, you know what is the differential count. Then you get platelets. Other than that, there's the red cell indices like MCD, MCH, MCHC, the hematocrit, that is the PCV, ESR. There are many indices like this. Okay. And peripheral blood smear is included in the CBC. That's when you have to make a smear and do a Leishman stain and see under the microscope and write the morphology of the red blood cells, white blood cells, and platelets. So in complete blood count, the hemoglobin and red cell indices are reduced. It's a microcytic hypochromic anemia. In PBS, the first and foremost thing that you get is anisopoikilocytosis. What is the meaning of anisopoikilocytosis? Huh? Change in shape and size. Which is shape, which is size. Which is size. Anisopoikilocytosis. What is anisocytosis then? Joseph. So anisocytosis means change in shape, and poikilocytosis PP. Anisocytosis means change in size, means microcytic or macrocytic, and poikilocytosis means change in shape, like teardrop cells, cystocytes, bite cells, fragmented RBCs, stomatocytes, leptocytes, etc., etc. So you get anisopoikilocytosis change in size and shape. এই এদিক দিয়ে হাঁটলে না এরা মানে বিচ্ছিরি সাউন্ড করছে, যাবো। Microcytic hypochromic red cells. You have studied in iron deficiency anemia. Microcytic hypochromic red cells. Target cells, আসছি এগুলোতে। Basophilic stippling means iron deposition. ঘুমোচ্ছে যাত্রীরা? হ্যাঁ? ঘুমোস কেন ক্লাসে? NRBCs. What are NRBCs? What are NRBCs? Nucleated red cells. NRBCs, nucleated red cells. If you do a complete blood count of thalassemia where there is increased NRBCs, it will give you a false, the total count will go up to 1 lakh. Total count can go up to 1.5 lakh. It will give you a false impression of leukemia. But that's when you have to do a corrected WBC count. Because these lymphocytes are recognized by this cell counters as lymphocytes. And they give a false impression of leukemia. The total count will go up to 1 lakh, 1.5 lakhs, 2 lakhs, etc. So you have to do a corrected WBC count in that case. As you have to count the number of NRBCs per 100 WBCs and do the corrected WBC count. Only then you can arrive at a diagnosis. Arrive at a correct complete blood count. Otherwise, clinicians will bang you. You all at the count. This is not a case of leukemia. It's a case of thalassemia. Why so much of count? Okay. Then supravital stain jodi koro with methyl violet and seen under phase contrast microscopy, you can see the alpha chain inclusions. The alpha chain inclusions can be recognized or can be seen with methyl violet under phase contrast microscopy. Iron status. What will happen in iron status? Iron status? Because of increased absorption, there will be increased serum ferritin and transferrin level. So TIBC te ki hobe tale? What will happen? Then bone marrow. In bone marrow, there will be erythroid hypoplasia, the myelopoiesis and megakaryopoiesis means WBC and platelet series, the platelet lineage will be. So laboratory evaluation go like this. You go for a complete blood count, when hemoglobin and the red cell indices will be reduced. Then in peripheral blood sphere you get anisopoikilocytosis, means first and foremost change in size, microcytic hypochromic red cells. Hypochromia is not size but rather change in color because of underhemoglobinized, because of less hemoglobin formation, sense of color, correct. Then you get various target cells, basophilic stippling, NRBC means now change in shape, poikilocytosis. You get leptocytes, which I mentioned korini, teardrop cells. It a normal blood counter chole gelo. Now to demonstrate the synthesis, the inclusions can be demonstrated by supravital stain. The inclusions can be demonstrated by supravital stain under phase contrast microscopy, which identifies the alpha chain aggregates. Iron status, just opposite to iron deficiency anemia, where serum ferritin and serum iron reduce, serum ferritin and serum iron will be increased. And TIBC will be increased in iron deficiency anemia, whereas CIBC in this case is what? Reduced. In bone marrow, there will be erythroid hypoplasia. The ME ratio will be altered, and at myelopoiesis and megakaryopoiesis, that is WBC and platelet lineage, it will be normal. Okay. So these are the target cells. You know how target cells look like. Thalassemia class, I'll be taking it practical. So I'll be explaining. I'll show you the pictures. Target cells look like. Then, take Badiker picture ta, it's a teardrop cell. You know how a teardrop looks like. Okay. Then you get the nucleated RBCs. Nucleated RBCs. And on the right, what are those dot things? So within NRBCs, you're getting basophilic stippling, probably. Okay, so this picture is clear. In special tests, if you can mention it, very good. If you can mention it, very good. It's not even in Robbins. Clehort's test is known as Clehort's-Bethke test. Here, basically, if you see this picture, what are those red cells? These red cells, they contain fetal hemoglobin. Okay, cells with HbF are well stained. So these cells, see this picture, the schematic picture, and compare this picture, microscopic picture. These red colored cells, they have HbF. They have HbF, fetal hemoglobin. So they are well stained by Clehort's technique. Whereas the white cells, these cells have HbA. They are not stained at all, or they are very faintly stained, resulting in a ghost appearance. Okay, so these are known as ghost cells. These are known as ghost cells. Okay, so this technique is known as Clehort's-Bethke test, but Clehort. So remember this as Clehort's test. And finally, you get the hemoglobin electrophoresis. Finally, you get the hemoglobin electrophoresis. Very simple. The normal pattern, normal adults will have HbA. Isn't it? The normal pattern will have HbA. There will be predominance of HbA, alpha 2, beta 2. Whereas when you look at this particular picture, see the difference of the HbA band in normal pattern versus in beta thalassemia. কতখানি reduced synthesis দেখা যায়, isn't it? And here, HbF will be reduced in normal pattern, whereas in beta thalassemia, HbF will be increased. HbF will be increased. So this finishes this topic on beta thalassemia, exactly how you're going to approach if you get this question in the exam. And this Monday, if you all are okay with it, how many of you are having problem regarding the clinical questions? How many of you are having a problem regarding clinical questions? Can you answer the questions? Because there will be a clinical problem, and if your diagnosis is wrong, you get 0. How many of you have a problem? Some of you have a problem. So this Monday from 3:30, I'll be taking a class on clinical problems. And in your clinical problem for this exam, you're going to have, I have purposely avoided hemodynamics. I have omitted hemodynamics, clinical problems from hemodynamics. You can get shock as a clinical problem, you can get embolism as a clinical problem, but somehow I'm not doing that. So I'm telling you, I've confined to only hematology. So in hematology, what clinical problems can come? Iron deficiency anemia, pernicious anemia, thalassemia, sickle cell anemia. From RBCs, these are the most important, these are the topics that can be covered for main questions. So this week, because there's a request from some of you, I won't name who those persons are. So 3:30 to 4:30, I will take a class regarding clinical problems and certain things which you're going to have for practical examination. Okay, you know how practical examinations are held? I'll explain. So if you're willing to come, you're welcome. If you're not willing to come, no problem, no attendance will be taken.